treat for you today.
We do?
You bet your fur we do. Today's mnemonic is maple.
Pancake!
No, Sal. Maple, as in the causes of megaloblastic anemia, like drugs and stuff.
Drugs!
No, Sal. Methotrexate, AZT, phenytoin, liver disease, ethanol, maple.
So no pancakes or drugs?
No.
You're just no fun at all!
All right, let's take a look at page 2 of your handout. Go ahead and answer question number 14, and then we're going to go through that answer together. So number 14, first bullet, microcytic anemia with swallowing difficulty and glossitis. This is classic for Plummer-Vinson syndrome, which is associated with iron deficiency anemia. Microcytic anemia with greater than 3.5% hemoglobin A2. This is beta thalassemia minor. Megaloblastic anemia not correctable by B12 or folate. Think about orotic acid urea. Megaloblastic anemia along with peripheral neuropathy. Think about B12 deficiency here. Microcytic anemia with basophilic stippling is lead poisoning. Microcytic anemia reversible with B6 was the sideroblastic anemia. HIV positive patient with macrocytic anemia. We said that zidovudine can cause this, so this patient may be on zidovudine, causing a macrocytic anemia. Normocytic anemia with red urine in the morning is the paroxysmal nocturnal hemoglobinuria, and normocytic anemia with elevated creatinine is chronic kidney disease resulting in low erythropoietin levels. All right, let's talk about your extrinsic hemolytic anemias. So, it's called extrinsic not because it's happening outside of the vessel. It's called extrinsic because something extrinsic to the red blood cell is causing the hemolysis, maybe an antibody. So on page 353, first one mentions is autoimmune hemolytic anemia. So you can have a warm agglutinin hemolytic anemia or a cold agglutinin hemolytic anemia. So warm agglutinins or IgG, chronic anemia seen with lupus and CLL and with certain drugs like methyl-dopa. And cold agglutinins or IgM, acute anemia triggered by the cold mycoplasma pneumonia infections or infectious mononucleosis. What causes that? Epstein-Barr virus, right? Take a look at page 2 of your handout, number 16. Cold agglutinins. These are antibodies against red blood cells that interact more strongly at low temperatures than at high temperatures. So if you have cold agglutinins around, it's not going to cause any problems unless those cold agglutinins are around cold temperatures. And when that's the case, then they bind to red blood cells and they cause anemia from that. So second bullet, these are nearly always IgM and occur regularly in infections with, we just saw mycoplasma pneumoniae and also Epstein-Barr virus, mononucleosis, but also some malignancies. Your book doesn't mention malignancies, but the three scenarios where you would have cold agglutinins, mycoplasma pneumonia, Epstein-Barr mononucleosis, and some malignancies. And again, the last bullet here, problems disease occurs when there is circulation to a cold extremity. IgM binds the RBC antigen. You have complement fixation and then a membrane attack complex lysis because of the complement. Warm agglutinins are slightly different. So it's also autoimmune because of antibodies, but the antibody is different. The scenario is a little bit different. So looking at number 17 on page 2, these are antibodies that react against red blood cell proteins at body temperature. So this is just going to happen. You don't have to have a cold environment. The second bullet, these are nearly always IgG, and seen in four main things here. Viruses such as Epstein-Barr virus and HIV can cause this, but typically we think of those as being associated with cold agglutinins, but viruses can cause it. Your book mentions SLE, systemic lupus, is the second one. The third one is malignancies, and the one that your book mentions is CLL, but also non-Hodgkin's lymphoma can have these warm agglutinins. So to reiterate, you have number one, you have viruses like mono or Epstein-Barr virus and HIV. Number two, you have systemic lupus. Number three, malignancy like CLL and non-Hodgkin's lymphoma. And then number four, you have some congenital immune abnormalities that can cause this as well. So it can be a congenital problem. Okay, so moving on, in your book, it also mentions under the autoimmune hemolytic anemia as a slightly separate topic, erythroblastosis fetalis. Seen in newborns due to Rh or other blood antigen incompatibility. The mom's antibodies attack the fetal red blood cells. We mentioned this in the immunology section and how the mom needs to be pre-sensitized to a fetus's red blood cells. So it's not going to happen with the first pregnancy, but it could happen with subsequent pregnancies. So I'm not going to dive too much into that because we've already discussed that in the immunology section. The next thing it mentions is autoimmune hemolytic anemia are usually Coombs positive. So what is a Coombs test looking for? Well, take a look at page 2 of your handout, number 15. Coombs positive, what does that mean? It says that red blood cell agglutination with the addition of anti-human antibody because red blood cells are coated with immunoglobulin or complement protein. So basically you're looking for antibodies to red blood cells. The direct Coombs test is where you have prepared antibodies are added to a patient's washed red blood cells. So you wash off the red blood cells so that they're free of any antibodies, and then you have prepared antibodies against those red blood cells. Well, you wash them as best they can so that any loose antibodies are away, and then these prepared antibodies are going to bind to antibodies that are on the red blood cell. So you're using an antibody to detect an antibody that's already bound to the red blood cell. So the presence of immunoglobulins already present on the red blood cell is what you're looking for. When do we use a direct Coombs test? We use it for hemolytic disease of the newborn to make that diagnosis. We use it to make the diagnosis of drug-induced autoimmune hemolytic anemia and also hemolytic transfusion reactions. Now, the indirect Coombs test is a slightly different test where the patient's serum is incubated with normal red blood cells to detect the presence of antibodies. So basically, you are not looking at the red blood cells this time, you're looking at the antibodies themselves to see if they bind to the red blood cells. So here, you're going to use this, and it's going to be positive to detect antibodies present in foreign blood. So if you're going to screen blood before transfusion, that's a scenario you do an indirect Coombs test, and then screening for maternal antibodies to a fetus's blood is another scenario of doing the indirect Coombs test. So you're looking for the same thing here, it's just a slightly different test for slightly different scenarios. Moving on to the microangiopathic anemia on page 353. So here red blood cells are damaged when passing through obstructed or narrow vessel lumen, like with DIC, TTP-HUS, lupus, malignant hypertension. So we talked about this earlier with schistocytes. There's mechanical destruction of red blood cells. Basically, you force the red blood cell to be sawed off by like a fibrin strand, and so you have these crazy-looking red blood cells that have pieces sawed off of them. And moving on, macroangiopathic anemia, prosthetic heart valves, and aortic stenosis may also cause hemolytic anemia secondary to mechanical destruction. And then infections are going to result in the increased destruction of red blood cells. Certain infections include malaria and babesia. The Maltese cross form of babesia, you might remember that, and malaria has the trophozoite form, and anyway, we're not going to go into that. We talked about all that in the microbiology section. Heme synthesis, porphyrias, and lead poisoning. So there's a few main points to know on this page. Number one, you got to know what the rate-limiting step of heme synthesis is. Look towards the bottom of the page, and you see that you start with glycine and succinyl-CoA and make aminolevulinic acid, and you use B6 in that step, and the enzyme is aminolevulinate synthase, or in other words, aminolevulinic acid synthase. Those terms can be used interchangeably. Aminolevulinic acid is aminolevulinate. And that is the rate-limiting step, so definitely know that. We've already talked about lead poisoning. You definitely need to know acute intermittent porphyria and porphyria cutanea tarda. So these are two diseases you need to be very familiar with. Let's talk about intermittent porphyria first. The main thing you need to be able to do is identify the presentation of this disease. How does it present? Painful abdomen, kind of like an acute abdomen. So very painful, kind of like appendicitis or diverticulitis or ectopic pregnancy type of a painful. But, of course, none of these pathologies are present. So painful abdomen with a normal CT scan and no reason why the abdomen should be painful. And the reason why it's painful is because of neurologic dysfunction. All right? This is a neurologic dysfunction that causes this painful abdomen. Port wine urine, so very dark port wine urine. Polyneuropathy, again, this is a neurologic dysfunction that's taking place. Psychologic disturbances, again, neurologic dysfunction causing psychologic problems. Precipitated by drugs is the last one. Treat it with glucose and heme, which inhibit the ALA synthase. All right, so definitely be able to recognize that. So I use the acute intermittent porphyria to think of acute abdomen and acute psychosis, and that helps me remember what this disease is. Now the next one, porphyria cutanea tarda. Porphyria cutanea tarda is is a cutaneous problem primarily, right? So think of this more as a cutaneous disorder. In the margin there, it says you can also get tea-colored urine with this one. And blistering, cutaneous photosensitivity, it's the most common of the porphyrias. And so more specifically, you have blistering on sun-exposed areas of the skin, like the dorsum of the hands and possibly the face, so blistering there. And there's other unique things that also go with porphyria cutanea tarda that are worth writing in here. Hypertrichosis, so excessive hair growth, hypertrichosis, facial hyperpigmentation, Hepatitis C is associated with porphyria cutanea tarda, as is alcoholism. And even though you may not have hepatitis C or alcoholism, porphyria cutanea tarda is nearly always associated with elevations of your LFTs like AST and ALT as well as GGT. So elevation of your LFTs, but it may also be associated with hepatitis C and alcoholism. So when I think of porphyria